Well, hello everyone, and welcome to the three things COVID-19 taught me about pre-hospital ultrasound. I'm delighted to have you all here for this educational opportunity. This webinar is being recorded. Now, on the next slide, let's take a look at your agenda. During today's webinar, you will hear about going beyond sliding signs, progression of the COVID-19 sonographic findings, and why the phased array transducer is the true workhorse in emergency medical services. Now on the next slide, it's my pleasure to introduce Tyler Christofoli. Tyler is a flight paramedic for LifeLink 3 in St. Paul, Minnesota. He is a co-creator of the Foam Frat blog and podcast and an active educator for Flight Bridge Education. Welcome, Tyler.
Thanks so much, Eureka. So we are going to talk about three things COVID-19 taught me about pre-hospital ultrasound. But for those of you who do not know me, I'm going to give you a quick little summary of my last 10 years. So I started off my career working for a private ambulance service in West Bend, Wisconsin, and I spent 10 years there. I eventually became the training officer there and worked closely with some colleagues. There's me right there helping guy learned to use the bougie, and I loved it. It was great, but I got real comfortable. And so I decided I need to do something else. I need to pick up the pace. So what I did is I got sick of chasing around people and telling them that their CPR was going to expire and teaching PALS classes. So I packed up my office, which looks like a child packing up his playroom. But yes, this was my office. I packed it all up and I thought, all right, you know what? There is an opportunity. There's a company called LifeLink 3 out of Minneapolis, Minnesota. So I picked up the family, and it helped a lot that my wife was from Hudson, Wisconsin, and we moved to Hudson. And so I started. I was the new guy again. I was working at this company. I was now a flight paramedic, which, was really cool. I always thought that would be a fun outlet as a paramedic, is to be able to fly and land and take care of really sick patients. And so I started working at LifeLink, and it was cool because they had so many tools. We had the Lucas, which I know a lot of you guys already have that. We didn't have it where I worked before. We had point of care lab testing. But the one that blew my mind and the one that I use the most, and I literally take it out on every call and put it in my pocket, is the ultrasound. And so for the first 6 months to a year, actually, I still do this. My partners can attest to this. You'll find me laying out by the helicopter with the ultrasound probe in my hand and the screen, looking at all of my organs and, oh my God, what's this? What's that? But trying to get good at it because I'd never used this before. And so I thought, I really want to be proficient with this. And there's so many resources online. There's EMS Pocus. My buddy Chip Lang has an excellent course that he does. I'll give you the information on that towards the end. But there's so many options to get really, really good at this. And it's something that I think EMS can embrace. And the reason I really liked it was because I remember, I always used to wear my stethoscope around my neck. And the stethoscope doesn't really work when you're in a helicopter. If you're documenting that you have bilateral lung sounds in a helicopter, people start to question your integrity to documentation. It doesn't work. So we need something to actually see breath sounds. That makes sense. And so the exams that we're initially familiar with when we think of emergency and critical care ultrasound is the RUSH exam, which is the rapid ultrasound for shock and hypotension. And then the FAST exam, the focused assessment sonography in trauma. Now, what do both of these exams have in common when it comes to lung ultrasound? Well, all we're looking for is things that would cause hypotension. And so we're trying to rule out a pneumothorax. And so we're only looking for sliding signs. Now, do you guys know what sliding signs are? You can feel free to throw it in the chat box. Has anyone ever heard of sliding signs before? Sliding signs are something that's a pinnacle point. Yeah, so what are sliding signs? What is that showing me? Well, I built this schematic because this is how my brain works when I'm trying to think of how this stuff plays out. You're going to see a lot of this today. So here's the chest wall, and we have a rib, and then you got the rib shadow under it, another rib and a rib shadow, and this is your nerve, artery, vein that kind of go underneath the costal margin. And this right here is lung. And so right here you have your visceral and parietal layer. And there is a potential space between there. So I'm going to circle this. And they call this the VPPI, the visceral parietal pleural interface. And so if somebody doesn't have air trapped in there, you should see it slide. It should go back and forth. You guys better appreciate this animation. It took me like 20 minutes right here. So you see it going back and forth. That's what we're looking for. And so if you were to see what this looks like on actual ultrasound, it looks like this. So you got your rib shadow, rib shadow, and you can see it sliding back and forth. Now, the way the probe is placed, and I'm not going to get into a bunch of probe placement stuff on here because the best way to learn that is just to go to a workshop and actually pick one up and demo it and play with it. But I have this looking with the probe marker facing towards the head. And so we're going to say that this is a short axis view of the ribs, but it's actually a short axis view of the lungs, but a long axis view of the ribs. And let me show you why. So when we're talking about long axis, I want you to imagine you're standing here on this road and you're looking down and you see it long ways. And when we talk about short axis, we're actually just standing on one side of the road and looking across to the other side of the street. And so that is what we're looking at here. You can see we have our ribs here. And so we're getting those short views of the ribs here. And this isn't the whole rib. Like we said, this is just the shadow of the rib. But we're really zoomed in here. You see how zoomed in we are? We can see our rib and our rib shadow. But what about all that other stuff? What about all the lung underneath here? And so I started to realize that the majority of my lung ultrasound skills were pretty superficial. And you can see the linear probe right here, which is the one we use for looking at sliding signs or IVs, things really close to the surface. And the lung is saying, you are always so superficial with me. And so I realized that I needed to extend my knowledge of ultrasound, but I didn't just realize this on my own. I realized this in 2020 because I had gotten, so focused on the rush exam and the fast exam that I really wasn't paying attention to things deeper. I wasn't going below the surface. And then 2020 came along. And even though it's been one heck of a year with the current pandemic, the SARS-CoV-2, COVID-19, started to make me dig into lung ultrasound a little bit more. And so I think the majority of people now understand how this virus worked, but you got the virus that comes in, and this is like your alveoli here, and you got your type 1 pneumocytes, and this is like where gas exchange occurs. But the type 2 pneumocytes have this little ACE2 receptor, and the SARS-CoV-2 binds to this ACE2 receptor, and it goes inside the cell. And then it starts to replicate, and then it produces, and it's in the cell. So it's kind of under the body's radar. Like they're not seeing it. And then eventually somebody takes one of the little spikes and says, hey, dude, there's something in here that's replicating. You might want to focus. And then all of these cytokines, these inflammatory mediators come out. And that's where we start to see things develop like pulmonary edema. And so this made me think, I have an ultrasound machine right here. Is there anything that I could see on ultrasound that would make me think that there's some sort of viral process going on? And even if it's not COVID-19, what about just like assessing fluid response or fluid tolerance? If I give somebody 500 mLs of fluid and I start to see some fluid appear in their lungs, what would that look like? And so they started to release a ton of videos on YouTube on this, lung ultrasound findings, preliminary studies, clinical radiology, and then actually the Philips Lumify. The Philips received FDA clearance for the use of its ultrasound portfolio to manage COVID-19. And it was actually the only ultrasound unit that got this clearance from the FDA. And so I thought, all right, I got to dig into this a little bit more. What are people saying they're finding when they're scanning the lungs on patients with COVID-19? And the reason I think this became so popular is because the CT is great, right? I think that a lot of people were thinking they might use CT for screening, but you got to worry about radiation. And then in addition to that, you take a patient through the CT scanner that has COVID-19, and you have to completely take that CT scanner out of commission. You got to decontaminate it. So is there things that we could see on ultrasound, and then what would be the events that we would see, and how would that progress? And so I started digging into the literature, and it seemed like there was a timeline, and went from day 0, 3 to 3 to 7, 7 to 14. And so it starts off with B lines. And you might be going, I don't know what B lines are. We're going to talk about that. Irregular pleura, we're going to develop that, and then hepatization. And so I saw these words, and right now I was probably the same with you. I'm like, no idea. So all I've been ever doing is lung sliding, which seems very elementary now. I was just looking for the sliding sign, and we'd jump in the back of an ambulance, and they'd be getting ready to needle somebody, and we'd be like, oh, let us just look at the lungs real quick. And I can remember a couple of times they'd be like, no, we don't hear lung sounds here, we got a needle. And you throw the ultrasound probe on, and there'd be clear sliding. And so if you see sliding, there's not a pneumo. And so, but they say, if you don't see sliding, that doesn't necessarily mean it is a pneumo. There could be other things at play. But if you see sliding, you don't need to put a needle in their chest. And I often wondered, how many times are we inadvertently putting a needle in somebody just because we can't hear? You guys can see behind me, I was a musician for over 10 years, and I have lost my hearing. I cannot rely on a stethoscope. It's just about as reliable as me trying to feel a pulse. And so I really liked ultrasound for that reason, but I needed to develop a better understanding of lung ultrasound. And I have a lot of good friends, and I dug into the literature, and I picked their brains, and I developed 3 things COVID-19 taught me about pre-hospital ultrasound. So I hope you guys enjoy this. And if you have questions, like Sharika said, start typing them in the chat box as I go along. And I'll try to collect all of those at the end, and I can explain them. All right, so let's start off with the very simple one. What is a B line? You guys ever heard of B lines before? It took me forever to try to figure out what B stood for. And so I always like to know the reason behind this, especially if I'm going to do a talk, because I'm like, there's going to be one person that says, hey, what's the B stand for? And so when you're looking at like a chest CT, there was something called curly B lines. And his name was Peter Curley. He was a radiologist, and he labeled, like, they had the curly A, curly B, curly C. So the B doesn't stand for anything. It was just a category that they used. But what is it? What is it telling us? Well, here is the lung here. And I want to zoom in on one of the lobules of the lung. So let's zoom in right here. And we're going to look at the terminal bronchial, where it turns into the alveoli, the parenchyma of the lung, where the work happens. So this is what it looks like. So I want you to imagine these are all little tiny alveolar sacs in these lobules, and these are the primary lobules. That's what they're, just the alveolar units here. But this whole cluster of things is called the secondary lobule. And you can see that there's these little septums in between that divide it. And so we see some vessels here. Let's talk about what these vessels are. So this right here is the pulmonary artery, and it's blue, right? Why is the pulmonary artery blue? I thought that was oxygenated blood. Remember, pulmonary artery is oxygenated blood that's coming through the right ventricle into the pulmonary artery. So it is not oxygenated yet. That's why it's heading to these guys to pick up some O2. So it's heading down there, and it rides kind of right along the bronchioles here. And then we get inside the working unit, the parenchyma, the alveoli, and then we can come out. And this right here is the pulmonary vein going back into the left atrium here. And this yellow stuff is the lymphatic system. I'm not the best artist in the world, but these scribbly things are the lymphatic system, and those extend up through the top of these secondary lobules. Now, I want you to imagine a condition where these secondary lobules, which are made up of the lymphatic system and the pulmonary vein, imagine that we have blood coming back to the left atrium. It's oxygenated, it's happy, it's ready to go out to the rest of the body, and it's coming back to that left atrium, and it goes down to the left ventricle, but the left ventricle's sick. It can't pump the blood out to the rest of the body. So it's going to start to build up. We're going to build up pressure in the LV, and then we're going to build up pressure in the left atrium, and then we're going to build up pressure into the pulmonary veins, and it's going to back up. And what do you think it's going to do to these lines? You guys feel free to throw it in the chat box. What do you think is going to happen to these pulmonary veins that are around these primary lobules here? There's something that's going to occur. And as we start to back up the system, we start to fill these up and they become more apparent on ultrasound. Yeah, we're just going to get a backup of our piping system. Everything is backing up. And so because of that, we start to engorge these pulmonary veins. And we can actually see this on ultrasound. So I'm going to make these engorged. You can see them start to build up. Yeah, they start to fill up here. And so what does this look like? Well, we put our probe on. You see, we got the Phillips probe appearing up here. And we're going to watch, and we can actually see these interseptum, this lobule here between the septum. We can actually see this on ultrasound. Here it goes. Look at that. So this right here is the B line, and this is separating. This is that secondary lobule. We can see it on each side here. So we only see one here, so it's probably not that bad. It can't be backing up that bad. Maybe this is one that was real close to where the pulmonary vein went into the left atrium. But what we can see is that we do have something appearing here. So we can see these clear lines. Does everybody see that? So we're looking at the rib and rib shadow here, so we can kind of isolate it. So here's the rib, here's the rib, here's the rib shadow going down. And then we can see that septa there going back and forth. And that's indicating that something is making that wide. Now, it could be cardiogenic pulmonary edema, right? It could be from a backup in the system, or the heart could be completely fine, and it could be cytokines, inflammatory mediators, bradykinin that are causing the vessels, the capillaries, to become leaky, and it's actually leaking into that interstitium there. And so those are the things that we have to think about. Is this cardiogenic pulmonary edema, or is this not cardiogenic pulmonary edema? And the way I would tell that is you can really quick just look at the heart. And if you see the mitral valve hitting the septum and you see the heart beating on all cylinders, well, then you can say, all right, well, this is probably not cardiogenic pulmonary edema. This is probably a leaky capillary bed. Something is leaking in that interstitium there. It's almost like the body is detecting that there's something going on and it's opening up. And we see that same process in sepsis. That's why patients in sepsis get hypotensive. It's like a backflow in a septic sewer system. So that's when you're thinking about the backflow, that would be things like, all right, this patient can't take the fluid we're giving them and it's starting to back up, or start thinking that it could be a leaky capillary process that's occurring. So we generally want to see more than just one of these lines. So I'm going to show you this one right here. So you can see the ribs. You can see the rib shadows going down here. And you can see there's multiple B lines here. And they vary in depth, but we generally want to see it go past that 12 to 15 centimeter mark. And so when you're looking at the ultrasound, you can see all the ultrasound units have this little centimeter line here. And we want to make sure that that's extending down. You know, if you just see it go from here to here, that's probably just a little comet tail. And that's normal. That's normal to see those little things appearing there. A true B line really needs to extend down, and you really want to see around 2 to 3 per intercostal space before you start saying, okay, that's definitely a B line. Now, one of the things that was interesting is they were reporting some of the Italian studies on the SARS-CoV-2. They were saying that these B lines were real patchy. It wasn't like it was like everywhere. It'd be like you had 3 here, and then it would skip a couple costal margins, and then you would have 1, and then you would have like 4 in 1. It was real split up and patchy, and that was a kind of a signature thing that they were starting to see with this. And you know, a lot of the stuff doesn't have the hugest amount of database behind it, just because it's still developing. But I thought that was interesting. Well, you're thinking, all right, that's cool. I can detect a B line, but what does normal look like? What would a normal one look like? So here is a normal ultrasound of the lungs. This is actually me. I got my my little unit back here, and all the time I'm screening myself. No, I'm just kidding. So these are A lines right here. And so A lines are good. And I think of A lines as air because it's just reverberation artifact. And so what you're seeing is basically a reflection of the visceral-parietal layer here. And that's what these A lines are. Now, something that's cool is if you have a B line that's going, remember, B lines are going vertical, A lines are going horizontal. If you have a B line, it will extinguish these A lines, and you shouldn't see A lines if you have a B line. So if you see something that you think is a B line, but you can still see A lines, it's probably not. It's probably just something picking up and reflecting off the pleura. All right, so I talked about how deep you need to look with that ultrasound probe. I said you want to get down to like this 15 centimeter mark. You want to make sure it's extending out there. Well, what type of probe are we going to use? Well, there's really two different types of probes. There's three, but what I generally see in EMS is two. So you have your linear array. And this is what you would see people using in the ED when they're starting IVs on patients because it's very accurate. I mean, you can see nerve fibers, you can see everything very, very close, but it loses its gusto at about like 5-6 centimeters. You're not going to get that accurate. So if you're trying to look for things in the abdomen or the heart or even the deeper structures of the lung, you're not going to see it that well on a linear probe. What's nice though is if you were just looking for sliding signs, it becomes very, very clear that you can see sliding signs when you're using the linear probe. And this is when I was first starting to learn how to look for sliding sign. I would always use this because it was easy for my eyes to detect that. Now, the phased array is the one that I use the most. And this is the one if I'm running in on a call, a trauma call, and we're getting ready to get out of the helicopter, I take my phased array, I take the actual unit, and this just fits right in my flight suit pocket. And I can walk in and I have it all set to go because it's a little bit harder to scan in the helicopter. So I like to do it in the back of the ambulance because then I have 360 access to the patient. This one goes deeper. This one, as I was saying, like that 12 to 15 centimeter mark, it's going to be able to go in and look at the deeper structures. And so when you see this, and you see that the patterns that it has on it, this is what it would look like. So I just took some images here. So this is what a sliding sign would look like with a linear probe here. So you can see the muscle tissue, you see some subcutaneous tissue here, you can see the visceral parietal pleural layer here, and this is great. This is great if I was starting an IV or if I was just looking for sliding signs. But when I start to look at when I want to look at the deeper structures, I need something like this. And you can see how this kind of comes off this ray here. And it's kind of got it. Imagine it like a fan. It kind of comes off like a fan here. And I can look at B lines. I can look for deeper structures. All right. So where do we put our probe? Where do we put our probe at? So if I was looking for sliding signs, we're always taught to do the most anterior portion of the chest because if you think about it, that's where air is going to go. Air is going to go to the most anterior portion of the chest. But that's not where fluid goes. Where does fluid go? Fluid's going to settle in those posterior lobes. It's going to be back down here. And so when I'm scanning, I use the Lichtenstein model from the Blue protocol. And if you're not familiar with that, you can look up the Blue protocol for lung ultrasound. And essentially what you do is you separate the body into zones. And I know that the fluid is not going to be way up here. Now, you may have some consolidations that could appear up here, but usually when we're talking about hydrostatic pressure of a vessel, it's going to follow gravity. And so I use something that's called the lawnmower movement, and I thought it would be real clever if I added in a lawnmower here. You guys are just loving these. So this is the lawnmower move. So I'm going up and down, and I'm following through these zones here. And I'm following through each one of these. And so that was B lines. And then we said is on days 0 to 3 that we typically see B lines. But what about day 3 through 7? This is something that got a lot of press, is this irregular pleura. So remember we talked about that visceral parietal layer. We talked about the pleural lining there. So let's look at that. Let's dive into this a little bit. So the irregular pleura is we can go back to this diagram here. So remember we said we had this lymphatic system that kind of goes in between the septum of these secondary lobules here. And so we're going to say that we get some consolidations that appear right below the pleural surface. So we get these B lines that start to occur because we have leaky capillaries. So we got fluid accumulating in that interstitium. And then we got this lymphatic system here. And so we can start to get these little consolidations that appear right below the pleural surface. And so something that was very commonly reported is an irregular pleura. It kind of looked edgy and it wasn't nice and smooth. And so I'm going to show you a picture here of what that looks like. So you guys probably can detect this right away. You see that right there? It looks like it's like going over a speed bump or something. And so that could be a subpleural consolidation that is appearing there. That's a very obvious finding. You can clearly see this, that there is something going on right here. And so that is what that irregular pleura would look like. It wouldn't be nice and smooth, but there'd be little jagged edges. It would be broken up a little bit. And that's another thing that we're looking for to tell us that there could be some sort of viral process. This is very common in viral pneumonias. And actually, a lot of the things that we're going to talk about are not specific to COVID-19. You can see these in other viral processes. But if you have somebody that presents with a fever and they say that I think I might have COVID, because I'm sure everybody is right now. They're starting to use, or not starting, they are using ultrasound to kind of screen for these. All right, do they have B lines? No. Do they have subpleural consolidations and irregular pleura? No. All right, go home, let us know if anything changes. And that way they can send people home and they're not crowding up the ICUs. All right, so the last one I said I was going to talk about was hepatization. So what do we generally think of when we see the HEPA word, hepatization? Be thickened and irregular when it comes to the pleura. We think of the liver. So why would we be talking about the liver when it comes to the lung? Well, here is an alveoli, and we're going to say that embedded in these, we'll say this is the capillary system, and it got real leaky right here. And so maybe we start getting some things, bigger proteins, albumin starts to drop, go into here, and the water follows it. And we start to get an accumulation of fluid actually inside the alveoli. So if B lines were fluid in the interstitium, when we're talking about hepatization, it's fluid actually filling those alveoli. It's almost like taking a hollow organ and turning it into a solid organ. And there is not any more obvious solid organ in the body than the liver. And so I've contrasted these and I put them right next to each other so you can see this. So right here we have the liver, and we call this hypoechoic. So hyperechoic would be like these echogenic borders. You see how it's really white? That's hyperechoic. It's echoing really well. When we say hypoechoic, it's just not as bright as the hyperechoic. And then anechoic would be black, and that generally indicates free fluid when we see that black. So we're looking for hypoechoic structures. Now, this is the liver, this is the lung. And you can see how they look very similar when you look at the actual color and the grain of them and how they play out and how they reflect through the ultrasound. So if you see this, this is not good. This is once somebody's alveoli have absolutely filled with fluid, and it's going to be a battle to have any gas exchange that occurs on this patient. And that's strictly because it's completely filled with fluid. It's taking a hollow organ, which essentially the lungs, you could say, are, and turning that into a fluid-filled structure. And so if you see this, and like I said, this is not just SARS-CoV-2, COVID-19. This right here can occur with pneumonia, ARDS. You'll look at it and you'll be like, wow, that looks like the liver, and it's actually the lung, and that's bad. These are patients that are going to possibly require ECMO. You're going to be doing things like airway pressure release ventilation. You're going to be dialing up your PEEP. They're going to be harder to oxygenate. But it's nice to know that that's why. You can look at that, and maybe you'll see some areas that have this that have consolidations, which is the word that's used as consolidation. So B lines are infiltrations, and when you see hepatization, it's really consolidations. It's consolidated. Yeah, ARDS, nice job. All right. So I started to put all of this stuff together. I'm like, all right, I got to get better at ultrasound. I got to figure out how to do this. And I have that probe sitting right next to my feet. So what are the three things that I learned? Well, I learned what a beeline was. I wanted to start looking at the irregular pleura. I learned words like hepatization, so I could sound like I know what I'm talking about when I give a report. But really, if I boiled it down, the first thing was just picking the right probe. I was grabbing the linear probe, the one that only goes, 5 centimeters, 4 or 5 centimeters, to look at the lungs. And that's great for sliding, but I probably could just use the phased array, because what I was having to do was pick up the linear probe. I would look for lung sliding, and then I would take the linear probe off, and I would pick up the phased array probe, plug that in, and then I'd do the rest of my assessment. I could just do the entire thing on the phased array probe and not have any issues. And I could also use it to look deeper into the lungs. So picking the right probe was a big thing for me. And that's why we put in the agenda that the phased array probe is the workhorse of EMS, because this is the one that I'm throwing on. Now, if you're starting IVs, stuff like that, then the linear array is where you want to go. It's very accurate. That nice square picture that it gives you a wide view. And you can, I don't know if you can see it, but there's a little marker on the center here. That's where you would put your IV. That's great. Generally, I'm finding that I'm using IOs in the helicopter, but that's what you would use that for. So making sure you pick the right probe. The second thing is using the right depth. So I could use the phased array probe, but if I zoom in so far to see the sliding signs, and I think I see a beeline, to confirm that, I need to zoom out. I need to make sure I'm looking at that 12 to 15 centimeter mark and making sure it's extending. And generally, you want to see 2 per intercostal region. 2 to 3 is what they will quote, or what they'll say. And then the last thing I want to look at is knowing the characteristics, knowing what a beeline is, why it's caused. Like, I did not know that that secondary lobule and those septums, that those were things that were filling up with fluid or blood if it's backing up. And that's why we see such a clear line. Everybody just said, well, if you see lines, that means that there's fluid in the lung. But actually understanding the anatomy and the physiology behind that was a game changer. And I think when we teach ultrasound, we can't just teach what to look for. You have to know the processes that are going on behind it, because it completely changes how you look at this. This doesn't mean, oh, I got fluid inside the lung. This means I got fluid in the interstitium, possibly working its way into the lung. But if my lungs were full of fluid, I would see hepatization. And the other thing I really like this for is, if you completely took away all of the COVID-19 stuff, is we're often saying, all right, I'm going to give a 250 ml bolus. I'm going to give a 500 ml bolus. Let's see how they respond to it. Generally, these patients are laying flat, or, their head up just a little bit, and it takes nothing to throw the ultrasound probe on. So let's say that this was before a fluid bolus, and I can see, who remembers what these lines are called right here? You can throw it in the chat box. What are these ones called? These are A lines here. And so are A lines good? Do we like to see A lines? Yeah, we can think of that like air. And then now we give a fluid bolus. We throw the probe on, and now we see this. So let's start off identifying the structures. I love that you guys are interacting here. So right here we have a rib, right, and a rib shadow. What about this bright line right here? What is this? I think you guys can see my my mouse. What is this line right here? The VPPI. Nice job. The visceral parietal pleural interface. And then we see this line working its way down. What is this right here? Yeah. So can we say it's a true beeline, do you think? Does it have all the characteristics? So we can see it's extending past that 12 centimeter mark. But we probably would like to see maybe one other one appearing in there before. Because remember, these are what you're actually seeing is that secondary lobule, that septum going back and forth like this. And so typically, if you just see one, there's a chance that it's not actually leaking, because if it was leaking there, it should be leaking somewhere else. But this is definitely something that we would want to look at. And there's also, it's really cool, you can quantitate how much fluid you estimate is within that interstitium by how many of those B lines you see per costal region. It's just engorged at that point, and it's something that we want to monitor. But this is definitely not a patient that we want to put a liter bag on pressure bag infuser and hook it up to the patient and just to confirm these are B lines. I just want to make sure we're going to, you don't want to waterboard by throwing that on. So definitely want to avoid that. All right, guys, I hope that this was helpful. If you guys are interested in this style of learning and you like the graphics and the animations and the pictures, I welcome you guys to go to my site, foamfrat.com. We have tons of lectures. We are diving into the ultrasound world. We have you can see the Philips Lumify here. This is the one that we're using to film a lot of our videos, which is how I got connected with these guys, because I wanted to use a product that was very clear. And I tell people that it's kind of like when you're learning to play a guitar. You can buy the cheaper option of a guitar, and it's great, but people don't stick with it because you get blisters on your finger, and it's not fun. And so when I played around with the Lumify, I've played with all of them. We used a couple different products at LifeLink and at conferences, and I found that this one I could just teach the best with, and that's why I use this. And you guys can check this out. We'll have a whole section on foam frat inside the course on ultrasound as well. I have this podcast. If you go to foam frat podcast 98, are those really B lines? And my buddy Chip Lang, he's a PA. He's got a podcast called The Total EM. He's the guy I go to all the time. All right, man, what do you think about this? What do you think about that? And he does some EMS POCUS training as well. But we did this whole podcast here breaking down everything you just heard here. And they're also recording this. So you can go back and watch this video again as well if you guys like this. So those are the 3 things COVID-19 taught me about pre-hospital ultrasound. Like I said, I am not an expert on ultrasound. I'm learning. I'm a gifted amateur at this point, but there's so much more to learn. And that's why I use myself as the protagonist in this story, because I think it helps to see the progression of knowledge and saying, all right, we have this device. Why are we limiting ourselves to 5 centimeters when I could see a whole new world underneath that? All right. Sorry, guys. I didn't tell Phillips I was going to sing on this one. So if you guys are interested in contacting me, you can hit me up at @Christofoli88 on Twitter, or my email address, tylerchristofoli@gmail.com. All right, so now we get into the question and answer portion. So I am going to answer all the clinical questions. And if you have any product-specific questions, Andy Lippman is going to pop on. Andy, are you with us here?
I'm here, everyone. Hello, everyone.
Awesome, man. So they're asking who owns the device at which you attach the probe. So this Samsung tablet here.
Yeah. So with the Lumify model, and this is similar to others, it's a bring your own device scheme. So the device, the imaging probe, which has the beamformer, all the imaging mechanics and electronics are all built into the probe. So it's an off-the-shelf tablet. We work with Android, so that's just any Samsung device you can buy from Amazon, Best Buy, etc. We have a list of about 16 that we have tested and that are the latest devices. Samsung is a popular one, but there are others that you can plug into, and that information is published on the philips.com website. So the short answer would be Tyler owns that device.
Yeah, what's super nice is when you so you can have, if you want a bigger screen, you can have a bigger screen. If you want a smaller screen, I think this is like the perfect size for what I use it for, because often if it, like, the phone size is great. I've seen some people use their phone. I don't want to use my phone. Usually I'm covered in blood, or we're doing finger thoracostomies. Like, I don't want to have that all over my own device. So I'll use an external device. I'm not going to be taking out my phone. But the other thing that's nice about this is I can show the providers in the ambulance. So usually we're intercepting with, paramedics, and I can show them it and say, all right, do you see this right here? This is free fluid. This means that there's possible, blood, or it could be just regular free fluid in this space here? Or do you see that sliding sign? That's what this is. And I can actually teach with this like that. When you first turn this on, you have the option of getting into different views. So they have a bunch of presets on there, which is super nice. I really like that because I can go in and I can hit lung or I can hit cardiac, and it sets the frame rate and the presets to exactly what you need based off of that. So I don't know if you guys can see this all right, but there's like these little pictures on here. You got the lungs, the heart. The best thing in the world is you have a mom that just got in a car accident. She's pregnant and she's so worried about her baby. And I take the probe and I throw it on her stomach and they can see the baby's heartbeat. Like, there is not a drug in the world that has the therapeutic value that that has. So it's just been a great tool to have. It's my favorite thing on the helicopter. All right, so I see, I'm going to go through here. So somebody said, are these available for paramedics to purchase? Yeah, absolutely. And you can even get a unit to demo for your service. And Andy can take those. I'll actually have Andy weigh in on that in just a second. I want to take a couple of these clinical questions. Somebody said, do I use the M mode? Yeah, we didn't talk about the M mode at all. So there's this thing called the M mode, and essentially what it is you drop a line on the screen, and it just looks at motion. That's what the M stands for, is motion. And so if you don't have motion, you're just going to get these straight lines as it reads. And it's probably a lot harder to explain, but they call it like a barcode sign. So if you didn't have any motion, you would just have there one line and it would stay the same the entire time. If you did have motion, it would be distorted. And so people say it's kind of like you're standing on the beach looking out at the ocean. And if there's a clear delineation between those two, that probably means you have sliding sign. I don't know. I have a problem with like the description of like ants marching, and like I can never remember if I'm on the beach or if I'm in the ocean looking at the beach. So I don't like to use that. I'd like to get down to the actual anatomy of it. But I do know that there are a lot of people that if they can't really quantitate qualify if they're sliding signs or not, then they will drop an M line and they will look at that. The other thing is to make sure you're videoing these. So we video a quick 5-10 second clip on everything, and we actually upload it into something called QPath. And then we have residents at Hennepin, ultrasound fellows, or not residents, ultrasound fellows that go in and they say, hey, great view, make sure you get the tip of the liver next time. Or, hey, great view, make sure you do this or that. And they can actually give us feedback. So it's not just us, it's not just a free for all with us thinking we find things. Did you encounter any HIPAA issues using your own personal device? So I don't use this one that you see right here for LifeLink. LifeLink has their own ultrasound units that we use for them, and it gets assigned a run number, and then we upload that into a database. So I'm not using my own device. That's how you can get away. Because if you are using patient descriptors like a run number and you have that device on your own, then it absolutely could start to get into some muddy waters there. So the people that you see with their own phone and like their probe and they're taking it to work, you got to be a little bit careful. I mean, I don't think anyone's going to be like, hey, I recognize that beeline. That's John from down the street. But you are putting yourself at more of a risk. It's great if you can institute this from a system and a program standpoint, as opposed to just having your own. Have you used the React's tele-ultrasound capabilities of Lumify? Yes, I have, and it's fantastic. And it's great for teaching, because if I have something, hey, man, is this what you're seeing? I haven't used it on an actual call, but I have used this just within the kind of the Philips Lumify nerd group that I have to play around, because it's really cool to be able to have that tele capabilities. Are you guys seeing, Andy, anybody use this in the field yet?
Yeah, absolutely. So just a little bit more background on what this is. So this is an integrated feature that allows you to do a video call, sort of like a FaceTime call, together with live ultrasound streaming. So you're having a real conversation with the ultrasound as well being transmitted, anywhere in the world. Obviously, that allows you to collaborate there while you're in transit. In the case of LifeLink, if you're on a flight on your way to trauma care, and can be used for remote learning, for any number of ways of collaborating. So, yeah, it's important now more than ever with restrictions on travel and with caring for folks that may not have seeked care because of fears of COVID-19. So also it's being used, for example, in isolation units where there's risk of transmission between staff. So lots of different ways where if you can connect remotely and have that live ultrasound there between an expert and the user that's with the patient, it's just incredibly useful.
Yeah, absolutely. Thanks a lot, Andy, for weighing in on that. Generally, when people hear about ultrasound, their first question is, how do I get started with it? What do I need to do? And you can't just, I mean, you can just buy a bunch of probes and throw them at your service and say, hey, go on YouTube and watch these videos. I got this really cool video by this guy named Tyler. But that's not the best way to do it. You need to have a QA process put into play. And so there's options at the end of I saw somebody ask if we can upload these into our PCRs. We don't actually upload it into the PCR. It uploads into a separate portal and it gets assigned a run number. And then you have somebody in your community that reads ultrasound. You know, you go to your medical director and be like, hey, who's a sonographer that we can use? Is there a college here? Part of their fellowship program is doing some sort of like Q&A process. So they love it and say, hey, can you go through and review these? And when we're entering it in, we upload after every run, we upload the ultrasound and we go in and we fill out a worksheet and we say, all right, what is the scan? So we're looking at the right lung. Is sliding signs present? Yes. Are there B lines present? No. And then you type in a little description of like what the case was. And then that way the sonographer can go in, or the ultrasound fellow can go in and see it and say, hey man, I saw you called this a B line, but it was only like 4 centimeters down. And we can't really say that and they can give you that feedback. And that's great. My favorite thing to do is to log on there and try to see if they've written anything. And it's really going to depend on the person that's reviewing it, but it's just great process. All right, cool. The other thing people want to know is, does it extend scene time? Everybody likes to say it's going to extend scene time. Here's the thing. It may maybe a little bit, but I have not noticed it delays scene time. And if it does, it 100% makes up for it in your diagnostic capabilities. And we like to try to stabilize the patient and resuscitate before you aviate. And obviously there's some things that need you to just pick up the patient and go and do everything on the way to the hospital. But there's other things that this can really come into play and help out a lot. You think of something like a traumatic cardiac arrest. You get on scene, they have a patient that was awake, now they're not, they extricated them, and they're doing CPR, and you're wondering, okay, is this a medical that led to trauma? Is this a trauma that stayed trauma? And so you look at the heart and you see the heart's beating and it's doing this, and they're still doing chest compression. That's a heart that needs fluid, that needs blood, right? As opposed to you look at the heart and it's not doing anything. And so we can really start to take different curves as opposed to running every single arrest like it is a medical arrest and giving your EPIs and stuff like that. It helps to separate those and you can see what path you want to go down. The heart that's doing this doesn't need CPR. It needs blood. But you would never know that if you couldn't see through the chest. So it maybe extends scene time a little bit. I don't think we've noticed it at all, but I'm sure you can make an argument for it. But the diagnostic capabilities and what we're able to provide are just phenomenal. Do you find it's more difficult to obtain a good image of interpretation? Obtain a good image or interpretation of said image. Yeah, so one of the hardest things is, and honestly, this comes down to the device again, because if you have a real grainy image and you don't know how to dial in your gain and you're playing with it so much to try to get the perfect image, it can be very frustrating. The number one thing people fail at when they're doing ultrasound is not using enough lubricant. You got to use a ton of jelly. I have this big tub that I can use when I'm practicing like scanning myself. And when I'm in the helicopter, we have these little packets of like, so each patient gets their own. I just take that entire thing and I squirt it all on their chest here. And that way I have a pool of it, because if you're not using enough lube, it's going to be very hard to get that interface and to be able to see down. What do you recommend for paramedics on ultrasound? So is that for, you're talking about training wise or an actual product?
Yeah, it says what training do
Oh,
you
training,
recommend?
training.
Yeah.
So for training on this, if you can find somebody within your own service that is able, or not service, but like your medical director, a local resource that you can tap into, that's great. A lot of my training came from the free open access medical education community. So things like 5 Minute Sono podcast, the ultrasound podcast, the EMS POCUS handbook. There's a lot of resources for EMS and POCUS that are available now that weren't available even 5 years ago. There's video tutorials on YouTube as well. So that's where I would start when I first start diving into this, is looking at the stuff that's available through 5 Minute Sono, ultrasound podcast. But if you're going to implement this, it really makes sense to find a system to come in and teach your providers. And I would do a train the trainer, because I think that that's more consistent. So have people come in, train your field educators on how to do this, and then have them disseminate that knowledge. How do you study to remember and actually learn this information? I think the best way of doing that is understanding why you're seeing what you're seeing, and not just remembering like the signs and names and beelines, but knowing the process that goes underneath it. I'm a podcaster. I listen to podcasts all the time. And so when I'm trying to comprehend this, I say, all right, here's a beeline. Why am I seeing this? And I just go on a search. I mean, I got a whole library of books that I read. I don't know a simple process of doing that, but that's how my process looks now. And it also helps that I'm teaching all the time, and I have, a blog and podcast. I'm always looking for content, and that makes me dig in and kind of go into the particulars of certain processes. Are you guys coming out with a cardiac monitor that has POCUS integrated for EMS?
So I believe they may be referring to one of our monitors from our emergency care team. Philips recently purchased a company called RDT, and they produce a pretty unique monitor called the Tempest Pro. The Tempest Pro is capable of having integrated point of care ultrasound. I just want to make sure we're using that POCUS acronym quite a bit. That stands for point of care ultrasound. And so look for that in the future. We're hoping to integrate something like Lumify onto a monitor. So that is a popular request.
Yeah, I like that a lot. Although I kind of like just having it in my pocket as well. So I don't know. I'm tossed between the two. I think it would be great, but I saw a monitor that like does everything. Like, you have like your monitor, you have your ultrasound, and then I'm like, well, then I got to choose. It's like going to see a bunch of my friends speak at the same conference. Like, how do I know which one I want to go with? But yeah, it sounds like that could be an option. How much time are you spending doing POCUS evals on scene, and what difficulties are running into with POCUS in flight? So there's no issues with like the FAA when it comes to ultrasound. You do have to have it cleared. You have to make sure that you're talking to your program and you're not just grabbing some unit and throwing it in your pocket and taking it on an airplane or a helicopter. You have to make sure that there's an approval process that's into place, but we have not run into any issues. The only issue that can happen is if your product has to have internet access in order for you to use it. We put everything in airplane mode when we're flying, right? So everything is not transmitting out. And so if you have a product that requires internet access, you will run into an issue with the aviation guidelines. So you want to make sure that it doesn't have to omit a signal or transmit anything out to the internet or like the cellular towers. It's got to be able to operate in an airplane mode, which this one does fantastic at. More beelines mean more congestion and fluid overload. And that's absolutely correct, man. If you see more beelines, you can say that there is probably more interstitial fluid and probably working its way into the alveoli as well. And then what that looks like when it's completely full is that hepatization that we talked about. If you can only get one probe, which one do you recommend? Well, like I said, the phased array probe, this is the phased array probe. This is the one that I recommend if you're only going to get one, because it's the workhorse. You can do your entire rush exam, fast exam, whatever, but you can also look at the lungs and see the deeper structures of the lungs, look for B lines, and you can also see sliding signs as well on it. So if I had to just get one, it would definitely be the one that has the most application, and that's the phased array. The other thing I like about this, and it's not like I'm doing a product review here, but this right here, these cords can come off and you can actually replace the cord. So we all know in EMS, we break something, somebody cuts something. And so it's nice to have the ability to take the transducer actually off the cable, and you can just replace the cable. So if something happens to it, you don't have to buy an entirely new probe. Any experience with retinal sheath diameter measurement with CVA? So this is something that I absolutely think is the coolest thing in the world. You can actually tell from the optic nerve sheath that there's increased intracranial pressure. I'm not going to pretend that I've ever done this on a patient, but I have done this on myself. And you can do things like you take a Tegaderm, put it over your eye, and then put lube on it, and you can actually look at the dilation and the how big the optic nerve sheath is, and it's directly correlated to their ICP. I don't have any experience doing this, and I don't think I'm gutsy enough to do it on a patient because it's not one of our approved exams, but it's pretty cool, and I could see it on myself, and I think that that's pretty. It's funny, when you put the ultrasound probe right against your eye, you can actually hear the little Python crystals like going back and forth, and you can hear that like vibrating into your head. It's pretty cool. Yeah, if you guys like this, we are going to try to keep doing these. And so we just did lung ultrasound on here, but if you're interested in learning how you can use ultrasound to guide your direction in cardiac arrest, I believe we're putting together an entire webinar on that as well. So stay on the watch out for that, because we're going to do more of these, and I absolutely love the interaction that we're able to get. If you guys have questions for me, like I said, I have my email address and stuff on there. You guys can hit me up. Here is my email address, tpcristofoli@lifelink3.com. And then if you have any Philips questions, you guys can send those over to Andy. If you guys want to get a demo unit, if you want to try these out, you want to talk to your service, it's definitely something that's not up and coming. It's not even up and coming anymore. It's here. People are using it. And I think it'd be cool to do a whole session on how you can guide your cardiac arrest management with just one probe.
Well, thanks, Tyler. We really appreciate your presentation today. We really appreciate your ultrasound education as well. I think it came across very nicely. Everyone's really appreciates all the information that you were able to provide. We also wanted to thank Boundtree Medical for sponsoring this event. And with that, I'd like to say once again, thanks to Tyler Cristofoli and Andy Littman for answering questions. With that, we will close this webinar. Have a great day, everyone.